Congenital hypertrophic pyloric stenosis. It is the most common gastric outlet obstruction as a result of hypertrophy and hyperplasia of the muscular layers of the pylorus. Incidence: 3 per 1,000 live births. The frequency may be increasing. 4 times more common in males, especially firstborn. Increased in infants with type B or O blood groups. Associated with other congenital defects including TEF. Etiology: cause is unknown, but abnormal muscle innervation, breastfeeding and maternal stress in the third trimester have been implicated. Elevated serum PGs, reduced levels of pyloric nitric oxide synthase and infant hypergastrinemia have been found. Clinical presentation: 3 Ps of pyloric stenosis. Projectile vomiting. Peristalsis visible. Palpable mass, vomiting. Typical presentation is onset of initially non-bloody, always non-bilious vomiting at 4-8 weeks of age. Although vomiting may initially be infrequent, over several days it becomes more predictable, occurring at nearly every feeding. Vomiting intensity also increases until pathognomonic projectile vomiting ensues. Slight hematemesis of either bright red flecks or a coffee ground. Appearance is sometimes observed. Patients are usually not pale-looking or febrile. The baby in the early stage of the disease remains hungry and sucks vigorously after episodes of vomiting. Peristalsis visible. Visible gastric peristaltic waves that move from left to right across the epigastrium. Palpable mass. Unenlarged pylorus, classically described as an olive, can be palpated in the right upper quadrant or epigastrium of the abdomen in 60 to 80% of infants. Patients are usually not pale-looking or febrile. The baby in the early stage of the disease remains hungry and sucks vigorously after episodes of vomiting.
Investigations: 1. Serum electrolytes. 2. Blood gas analysis shows hyperchloremic, hypokalemic metabolic alkalosis. 3. Ultrasonography. 4. Barium upper GI study, shows double track sign and shoulder sign. Severely dehydrated children sometimes require several days for correction. If necessary, administer an initial fluid bolus of 10 ml/kg with lactated ringer solution or 0.45 isotonic sodium chloride solution. Continue intravenous therapy at an initial rate of 1.25 2 times the normal maintenance rate until adequate fluid status is achieved. Adequate amounts of both chloride and potassium are necessary to correct metabolic alkalosis. Surgical measures. Pyloromyotomy remains the standard of treatment, and outcome is excellent. Ramstedt pyloromyotomy remains the standard procedure of choice for hypertrophic pyloric stenosis. Endoscopic pyloromyotomy is a simple procedure and can be performed as an outpatient procedure. Preoperative treatment is directed toward correcting the fluid or acid base and electrolyte imbalances. Correction of the alkalosis is essential to prevent postoperative apnea. Prevent aspiration. 1. Feed the baby slowly. 2. Perform burping after feeding. 3. Position the infant in high Fowler's position on the right side after feeding. Postoperative care. 1. Assess wound site and check the vital signs. 2. Promote comfort. 3. Start feeding 4 to 6 hours after surgery as per the doctor's orders. 4. Encourage the parents to stay with child. 5. Support and reassure parents.